Okay, so we're here with the foot now at the on the table. So this is where we can get a bit of an idea of what sort of range of movement the actual ankle and the foot has. So we're going to go through our active range of movement first, which will incorporate flexion, plantar flexion, dorsiflexion, inversion, aversion. And that'll give us a bit of an idea whether or not there's actual pain within the ankle itself, or are we dealing more with a problem to do with the calf muscles or the actual the ankle itself. So we're going to get Mark just to go through his active range of movement, which means we'll get you to just plantar flex. So just push your foot down towards me, pointing your toe. Terrific. We're looking to see if there's any pain through the ankle at the back or to the side, or also the other component is whether or not they feel any pain through the anterior portion or the posterior portion of their calf muscle. Okay, now coming back up into dorsiflexion towards you. Terrific. Once again, is there any pain going in and around the ankle, or are we having more tightness through the calves and so forth? Now inversion, obviously we're looking at the foot going in, the ability for the foot to come in there. Any pain there, that's okay. That's fine. And then also out. So a lot of these tests here, back out, we're looking if they had an acute trauma related to, obviously they've rolled their ankle. The most common is the inversion, rolling the ankle rolling on into inversion and then rupturing these lateral ligaments. So there'll definitely be swelling around here. There'll be pain in both these dorsiflexion and plantar flexion, and also the eversion and aversion. So most of those range of movements will be implicated. It's now where we can do our passive range of movement, so we can try and isolate whether or not there's actually any inert structures that may be at the centre of their pain. It's also an opportunity for us to see what sort of range of movement and what sort of tensional load that we have on some of these calf muscles and also the anterior leg muscles as well. So we'll go into we'll go into plantar flexion to start with. So bracing under the heel and over the top of the toe and then bringing it down. Once again, seeing if there's any pain through there, that's okay. And then what that end field feels like. So there's a springy feel there, and whether or not they're feeling any tension through there. Coming back up into dorsiflexion. So we're pushing up, exploring that end range again as well, that end feel, and whether or not they actually feel any tightness through the calf there. Now, they shouldn't really feel any tightness in their calf in this position. It's something that we need to put a lot more load through there to get tightness. So if they're feeling tightness through here, it's probably indicative that they've got some tight calves. And in particular, probably that soleus muscle and gastros. Okay, if we go into inversion, so the idea is that we're taking the foot and inverting. So the idea is, once again, we're tensiling, loading these structures through here. If we've had an ankle strain, then there potentially may be some leftover tightness and in those perineal muscles. Taking over into inversion and then aversion. So the opposite movement there. Just an opportunity to feel that range of movement. Okay, we can move into our muscle resistive test now. So this is where we can load some of these muscles and structures around here, and that can give us, once again, also an idea of which structures are at play. So we'll take it up into dorsiflexion first, and then we'll get them to push down into plantar flexion. Okay, that's all good. Once again, wrap your hands over the top of the foot and coming back up into dorsiflexion. So make sure that they can get up there. Okay, and then place a load through there. Okay, and that's good. If we're testing aversion, so we need to take them into inversion. So we take them into that range of movement, and then we get them to obviously try and invert out of there, and that's okay there. Good. And the opposite way again, turning it and aversion. Okay, terrific. So once we've done our active range of movement, our passive range of movement, and our muscle resistive test, we can then move towards our special tests. So there's an opportunity for us just to quickly discuss some of the conditions that we see in relation to the foot and ankle. So there are some more sinister conditions associated with the calf that we need to be aware of, and that would indicate things like such as a deep vein thrombosis. Now, if that being the case, we do have a test that helps us try and put us into this the bracket of this particular type of condition. It's called the Homan's sign. Basically, it indicates whether or not there's a presence of what we call a DVT. The knees need to be extended, and then obviously all we're doing is that we're gently taking our client into dorsiflexion, and that will elicit pain through the calf region. Now, it will be severe pain. There won't only just be severe pain, there's probably going to be a lot of redness, there may be some swelling with it as well, and there'll probably be a feeling of feeling unwell as well. Your clients just won't have pain in their calf, they will have associated other sort of types of symptoms related to the problem of this this vascular condition. So it's important that we're aware of that. If you're having and eliciting severe pain just by palpating the calf muscle, and that it's red and it looks swollen, and they've got a lot of pain of a severe nature when you're doing a dorsiflexion, passive range of dorsiflexion, that may indicate that there's a DVT. If there's a ligament sprain, obviously that will be highlighted by the fact that there'll be a history of either rolling the ankle or having a collision. They're really not that difficult to assess because there'll be the history of the incident, the mechanism of injury. There'll also be swelling and there'll be dysfunction as well. So depending on the grade of the injury, they may have a grade 1 up to a full rupture and so forth. So if they've got a grade 1, they may still be able to weight bear, but if there's anything above the grade 1, they may have difficulty in weight bearing. And there'll obviously be a lot of swelling involved with it. There may also be some bruising with it as well. That being the case, there are a couple of tests that we can do if we have people who are unsure whether or not they've damaged their ligaments. So we can do some ligament testing. If we have the anterior draw test. So essentially we're testing these ligaments on the medial portion of our ankle here, the anterotalofibular ligament. So we're pulling the heel down and then pushing down onto the tibia and fibula itself. So the idea is that we're assessing whether or not there's any bounce and movement through there as well. So moving on from the ligament tests, we've also got another ligament test which we call the squeeze test, which is more in terms of assessing the syndesmosis, which is the ligament that runs through the front here and the retinaculum that runs through the front of the ankle here. We put the knee into a bit of flexion, and what we can do is we can come over and sit on the table here, and with the head of the fibula and the head of the tibia, pressing those together here, and that obviously then imparts pressure at the lower part of those two bones here, which stretches the ligament through the front here. Now once again there will be a mechanism of injury and obviously an associated trauma with that as well, and that's particularly quite a nasty injury as well. But once again, it shouldn't be that difficult to assess because there will be that mechanism of injury and obviously the swelling related to it. If we've got foot pain itself within the foot itself, then there's a whole range of conditions that may be involved. The one that I see quite a lot with from runners is the side of neuromas, which are just a collection of nerve cells within the metatarsals themselves. So the pain with that will be obviously worse when they're weight bearing and so forth. But one of the things that we can do, which is the Morton's test, which is essentially just squeezing the metatarsals together and then moving them individually between each other. And if there's a neuroma in there, then obviously that will elicit the pain in that area as well. If we're dealing with medial shin pain, such as medial tibial stress syndrome, which may be related to the tibialis posterior muscle, which is quite common in runners and for those of you who are involved in football as well. We can also do the tibial, we can palpate that tibialis posterior. It's probably best if we use this one here. So just popping the leg up like so. Here we have our gastro muscle obviously coming down, our soleus muscle underneath there. So we're going to palpate that tibialis posterior, which is the most posterior of all the deeper calf muscles down through here. So we're just wrapping around that tibia there and just squeezing in there and seeing if that elicits any of the types of signs and symptoms and pain that they're feeling. And you should be able to tell from one side to the other whether or not there's a problem there as well. If we're dealing with something a little bit more related to the back of the foot itself, and we're obviously highlighting the Achilles tendon itself there. One of the tests that is absolutely imperative to do when you're looking at treating or assessing these Achilles tendon problems is whether or not the actual tendon is sensitive itself, because it's not unusual to have pain and trigger point activity in your soleus muscle that will mimic Achilles pain, and so will your tibialis posterior. So when we're looking at this particular structure, it's imperative that we actually pick up the Achilles and actually give it a good squeeze and see if it is tender. If it is hypersensitive, then there's an indication that obviously it is the Achilles tendon that's the problem there. We may also get a lot of feedback through the calves when we're doing those dorsiflexion movements as well, and that may be indicative that obviously the calves and the soleus is tight, which also places a lot more tensile load through that Achilles tendon. So just squeezing the tendon and feeling whether or not it's actually sensitive or not. I've got it in this position where it's unloaded, so that will give us a good indication whether or not it's sensitive or not.